We're not live yet. 1 second.
Live.
Cool. We are live. Hello, everyone. Please type in the chat if you can hear us and if you can sadly see us as well. There's a bit of a delay normally. Perfect. All right. Cool. Perfect. Right. Okay. So my name is Dr. Amarinder Ruprai, and to my left of my screen is Dr. Ben Thorp, and we are some F2s in the UK, and we're presenting a talk on enhanced recovery after surgery. I'm going to be quiet now. Ben's going to kick us off, and I'm also going to disappear. Just tell me when you want me to change slides, Ben.
Yeah, of course.
All right. Cool. Bye-bye.
Yeah, so hello everyone. As Amarinder said, so I'm Ben. I'm a junior doctor and currently working in A&E in Bart's Trust in London. So today we're basically based this talk around ERAS, which for those who don't know is enhanced recovery after surgery. So that's sort of what the next sort of 45 minutes will be about. Do you want to move on, Amarinder? So the talk is basically going to be, we're going to sort of just very briefly discuss, for those who don't know what ERAS is, what it's for essentially. And then we'll break it down into its different sections. So we have the stuff that we can do preoperatively to enhance recovery, the things we can do intraoperatively, and then the things we can do postoperatively. Cool. So again, for those who don't know, so what is ERAS? So as we said in the title page, it's enhanced recovery after surgery. So it's essentially this multimodal, as it says in there, it's a multimodal perioperative care pathway designed to achieve early recovery for patients undergoing major surgery. So it's essentially a set of like evidence-based implementations that we can make pre and perioperatively to increase outcomes. So whether those outcomes are increased or decreased mortality, morbidity, decreased hospital stays, increased patient satisfaction, and things like increased bowel movement, and all the more niche things that are to do with the more focused surgeries. So that's essentially what it is. It's basically, I mean, it was founded by this gentleman who Amarinder's lovely has put a photo of. This talk's going to largely be about the colorectal specific ERAS, purely because that's one that was the first one that was implemented. It's had the most research into it. It's really had the most thought put into it. But actually, generally, all the structures are quite similar. A lot of the information that we'll be giving you is the same for all major surgeries. It's just the more niche things that are different. So it does sort of go across lots of different specialties. So that's all fine. Do you want to pop it on, Miranda? Fine. So we'll just talk first about what we can do preoperatively. I guess a lot of this was actually largely covered by Jen in our talk a few weeks ago about the preoperative assessment, which again just highlights how important that assessment is. That we're having these assessments done way in time, way before surgery, to figure out which features of a person who's having surgery need to be optimized way in time, so we have enough time to do it. So the things that we should be thinking about months before or weeks before are on the slide essentially at the moment. So the first element is information. So that's really just providing the patient with the information of what's going to happen and what they should expect. Again, everything we're talking about here is evidence-based. There's proof that these things increase outcomes. So for example, with information, the fact that patients know exactly what is going to happen, they know how long they'll be in theatre, they know that they might feel sick after, they know that they might be in pain after, they know that the bowels might not work after for a day or two. Giving that information to patients massively increases patient satisfaction and outcomes. Optimization and prehabilitation, similar things really. It's getting that person who's having surgery into the best best physiological and psychological state before we put them on the operating on the operating table. So whether that's optimizing them physically with physio, rehab, nutrition, and then also, again, just like the counseling of the operations and things like that. And then we'll just go on to talk about nutrition, anemia as well, because they're two of the really important things in optimizing someone before their surgery. So do you want to pop the slide on? So firstly, nutrition is a massive feature of ERAS, and it's really, really important. And again, it's one of the reasons that elective operations have such better outcomes than emergency operations, because we have the time to be able to deal with these sort of things. So patients who don't have the best nutrition or who are malnourished, we have enough time to be able to modify that. So early on, when we're looking at people, we can use screening tools such as MUST. I don't know whether that's sort of universal. We use it in the UK to assess if someone's malnourished. It essentially uses the BMI, whether they're acutely unwell, how much weight loss they've had recently, and if they've got any what other acute or chronic health conditions they have. Will give you a risk score about how at risk they are or how malnourished they are. So that can give us a pretty good idea of how we need to act going forward. And essentially, so we just need to make sure this patient is eating the right things and doing the right things before they have the surgery. It reduces their stress response during and after if they're well fed, and it reduces infections. So it's really, really important. And again, there's tons and tons of evidence to suggest that we should be doing this. There's lots of talk about very, very carb heavy meals the couple of days before surgery, very carb heavy drinks the day of surgery, obviously before the window where you're not meant to eat, but really, really smashing in the carbohydrates to keep yourself well nourished. Do you want to pop to the next slide? The next thing is anemia, and again, this is super important and really, really overlooked. I think for anyone who's ever worked on a surgical ward, who's in the chat at the moment, will know this. Lots and lots of people are anemic, and we don't really do much about it. We do kind of just see it on their blood films and go, well, everyone's anemic, and we don't do a huge lot about it. And there's some really interesting stuff about dealing with anemia preoperatively and how important it is. Obviously, we all know what hemoglobin does and why it's important. If you increase someone's hemoglobin, you're increasing their oxygen delivery to the tissues. I mean, it's a no-brainer about how that's going to help someone pre and post-operatively. So we really need to know and highlight who's anemic and why they're anemic, and then we can remedy that in time. Interestingly, there's a lot of data that when we were writing this talk, we found a lot of data about transfusions, blood transfusions, and actually how rubbish transfusions are perioperatively, and that the use of transfusions to sort of quickly top up people's HB actually has very poor outcomes compared to not using them. Why, we're unsure. I think Amarinder, we were talking about this briefly earlier, Amarinder had found some research to suggest that it might be due to an immune response of the fact that the blood is a foreign body essentially, and you're distracting your body while it should be getting psyched up for this really, really, really major surgery and this huge stress response. It's actually preoccupying itself with the fact that someone else's blood is running around its body. But the outcomes aren't good. So we really shouldn't be topping people up with blood. It doesn't work. So I guess the question goes, what do we do? If you want to just pop onto the next slide, Amarinder. So this goes back to the point of we really need to know what we're dealing with. We really need to know why someone's anemic. And again, this just goes back to med school. How do we work out someone's anemic, and how do we work out what's causing their anemia? We look at their blood, we look at the size of the cells, we look at the distribution width, we look at their diet, we look at all these different things, we look at their hematinics, the comorbidities, and we say, right, this is probably what's causing their anemia, and we try and optimize that as much as possible. Most people are iron deficient to a certain degree anyway. Even people who are B12 and folate deficient as well, topping up iron is always going to help. Iron tablets are great, but there's also, again, there's some really interesting stuff about iron infusions, which we've started using quite a lot on the surgical wards in my hospital anyway, preemptively to top up people's HB. And apparently they work really well. And there's really good research about the use of iron infusions perioperatively to optimize people's HB, which is really interesting. But again, this it just sort of nails in the sort of resounding point that we need to know in time, and we can't be doing these things a couple of days before surgery. We need to plan them in response and react in response. Cool. Do you want to flick on? Fine. So the next little bit is still preoperatively, but I guess it's more while we're in hospital. It's just before surgery. What sort of things can we do to get that person safely through theatre, and then afterwards, how can we quickly get them out of hospital feeling well, with good surgical outcomes? So we'll talk a bit about nausea and vomiting, how we're going to deal with that, what medications we can give preemptively to make people feel a little bit better and to improve outcomes, how we can use prophylactic antibiotics and like appropriate shaving protocol to prevent wound infections and skin infections. And then we'll just come on to a bit of fluidy stuff after that. Do you want to pop on? So again, I guess we all know how to deal with nausea and vomiting. Well, presumably, apologies if there's some sort of early med students out there. Why do we want to do it? Because it improves the satisfaction of the patient. Being sick is awful. It's one of the worst feelings in the world. If you're like that constantly for 2 or 3 days because you've had absolutely loads of opioids and anesthetics pumped into your body, it's not very nice. Keeps people in hospital. It makes them very dehydrated. It gives you electrolyte disturbances, and then it can increase your chance of aspiration and things like that. Again, intraoperatively or postoperatively. And again, we talked about how important nutrition is in a couple of slides ago. Well, that nutrition is pointless if you're just vomiting it out. So we really need to nail down antiemetics. Obviously, the antiemetics on the left are the ones we use. We use dopamine antagonists, serotonergic antagonists, and ondansetron, and then the cyclizine and things like that. We can get a pretty good estimate of who's going to be sick during operations. I think, if people have been sick before with anesthesia, if people tend to get car sick or travel sick. I know people who are pregnant, people who, I think young females are more get POMV more prevalent. So we just need to be on top of that and don't be scared to use more than one agent if we think one isn't going to work. I know that's something that we do a lot on wards, is we give one agent and go, oh, well, it's not working. Use another. Yeah. Okay. Do you want to pop on? This slide's about reducing pain and reducing anxiety. So this is sort of the physiological and the psychological that I talked about earlier, is trying to preempt the getting on top of people's pain and anxiety. Interestingly, there's a lot of data suggests that we shouldn't be using opioids perioperatively for a number of reasons. One, it messes with people's consciousness, which muddies the waters a little bit. And then obviously we know the response it has on people's bowels and things like that. Obviously, if someone's having colorectal surgery, the last thing we want to do is then give them loads and loads of opioids so their bowel doesn't work. We want to get that bowel moving as quickly as possible. The more we use analgesia before and during, the less they need after. which again is obviously beneficial to get someone home as quickly as possible. So paracetamol, NSAIDs, your gabapentinoids can all be used perioperatively to try and get on top of those sort of things. Yeah, so just remember that as well. The pain relief, don't just use it when someone's in pain. Think about it. If you're doing a massive laparotomy, that person's going to be in pain afterwards. There's no doubt about that, is there? Don't just try and treat the pain when you see it. Do you want to pop on? This bit's about the infection, so site infections. So we now use a lot of, especially in general surgery anyway, we use a lot of, and in orthopedic surgery as well, we use a lot of prophylactic antibiotics. So it's generally used, the anaesthetist will generally use it in the anaesthetic room before they get wheeled into the theatre. So it's meant to be in the 60 minutes prior to incision, which generally probably is. I know things are a little bit slower sometimes in the NHS, but that's how it's meant to work. Normally, from my experience, the consultant, the surgeon will tell you what they want. This isn't really an anaesthetic decision. A lot of the time, it's the surgeon who's making that decision. It's the surgeons who are saying, this is what antibiotic I want, or whether to give one or not. I guess at the end of the day, it's their patient, it's their outcomes. Always, obviously, prep the skin properly. Chlorhexidine is the best thing to use. And don't remove hair. There's no benefit of removing hair in surgery. If you really have to remove hair, because, for example, you're operating at a site that has loads of hair and it's going to get in the way, do not use razors, use clippers. There's a lot more site infections and skin infections if you use razors and then operate on someone than if you use clippers. But if you don't need to do it, don't do it. I think it was something that was historically always done, whereas actually now we've found out that it's pointless. Obviously, the sites that I'm talking about are sort of like head and things you've got to do, haven't you? But so again, as it says on the right, so it minimizes opportunistic pathogens. And yeah, there's lots of evidence for that. Do you want to move on? So fluid status. Again, we've actually had quite a lot of talks previously to this on fluid. We know how important fluid is. Part of ERAS, or one of the ethoses of ERAS, is maintaining someone as physiological as possible. It's having them in the most physiological state they can be before their surgery. We really, really like pumping people with fluids in hospitals to make ourselves feel better. But a lot of evidence suggests we shouldn't really be doing that. Don't overhydrate people. Keep them as euvolemic as possible. Try and avoid those prolonged fasts. Again, I know we've all worked on wards. We know how theatre lists work, especially in the NHS. We basically starve people all day. We have diabetics who are starved for 12 hours. People aren't drinking and eating for 12 hours because they've been nil by mouth since midnight and don't get operated until 5 p.m. So be sensible about when you eat and when you drink, or when you let them eat and when you drink. Keep electrolytes in range. Don't go overboard with replacing them. But obviously, if they are low, be sensible about replacing them. Interestingly, a lot of the guidelines now are suggesting don't use bowel prep, which again I have experience with, not myself. Not mine, not myself, but I've seen firsthand what bowel prep can do to people, especially old people. It really, really messes with them hemodynamically. Essentially, you're giving them a medication that causes them to just lose liters and liters and liters of fluids, which is actually really problematic in older people. It's definitely not what you want prior to surgery. You don't want someone very, very dry with absolutely messed up electrolytes before you operate on them. So if you can really avoid it, don't use it. Some operations, like rectal operations, you have to. You can't avoid it. But in a lot of colorectal and colon surgeries, you don't actually need to use it. So just be sensible about when it's being used and when it isn't. obviously, we know that don't eat for 6 hours. Clear fluids can stop 2 hours before. Again, this is a really important point that I think we all know, but I think people don't really do. Again, I just think from my experience on wards, people put people nil by mouth at midnight and just leave them. You can drink up to 2 hours before. So remember that. And it's, again, not just an outcomes thing, but it's a patient satisfaction thing. I've had surgery and I've sat in a ward for hours and hours and hours with no food and drink, and it's awful. It's really awful. Yeah. So obviously, why are we doing those sort of things? If you're euvolemic, you're maintaining your perfusion, you're maintaining your nutrition, giving people loads and loads of fluids. You're just diluting them. The fluid goes into the wrong place. The fluid dilutes your blood. It's just a suboptimal position to be in. And again, if the fluid's in the wrong place, if you're really edematous, you don't heal very well. So that's the final thing. Do you want to move on, Amarinder? Cool. So we'll just come on to the intra-op stuff now. So I'll just introduce this, and then Amarinder's just going to carry on with the rest of the talk and talk about the intra-op stuff. So intraoperatively, the things that we focus on, or the things that ERAS focus on, is what agents we're using for anesthesia. This has changed a lot through the years. The agents that we're using now are very, very different to what we were using 10 years ago, 50 years ago, 80 years ago. Normovolemia, we've just talked about. Normothermia, keeping it as minimally invasive as possible. I know all the general surgeons don't like doing all the laparoscopic stuff because it's boring and they get de-skilled in the big old surgeries that are funner, but there is a method behind the madness. And then finally, we just talk about drainage, and again, minimizing invasive procedures if we don't need to use them. So do you want to kick off, Amarinder?
Hello. Yes, I'm happy to continue. All right, cool. Thank you. Right. So as Ben said, I'm going to be talking about the intraoperative and the post-operative optimization, and just going through a bit of the evidence from both the European guidelines and the UK guidelines as well, for those of you who are planning to come or are in the UK. So the first thing I'm going to talk about is the standard anesthetic protocol. I'm not going to talk about anesthesia for the whole talk. It's just a little short pit stop. So mainly for when you're doing anesthesia for any procedure, especially on the elderly patients, you want to keep them at the minimal level of sedations where they're not in pain, obviously, and where they're not conscious, but you don't want to knock them out so much that their body's not able to produce a physiological response to the surgery. So there's been a lot of hype into something known as TIVA recently, which stands for Total Intravenous Anesthesia. So there's no gases involved. You basically set up a funky drip stand where you have a number of medications. So you normally have an opioid like Remifentanyl, and you normally have your sedating agent like propofol. And what you do is you also have these special stickers you put on the patient's head, and you get to see how active their brain is. And what the anesthetists can do is they can essentially, it's like creating a cake. They can optimize the ingredients to keep the patient at a minimal level of anesthesia, minimal level of cerebral function, so they know what the minimum amount of anesthesia they need to give. And it has many advantages, which are on the right. So number one, it minimizes post-operative nausea and vomiting. Number two, especially a lot of patients, especially the elderly, are having operations these days, especially the hip fracture patients. It minimizes post-operative cognitive decline. And I'm sure all of you have worked in a hospital, you've been on surgical wards where an elderly person has had surgery. All their bloods are fine, but they're not the same person they were before they came into hospital. And this may be the reason. It may be the lasting effects of anesthesia. So obviously we would like to minimize that for obvious reasons. Moving on next, this is just me being a bit nerdy about some anesthetic medications, but the main point of this slide is why remifentanil is so good. So ignoring all the text and ignoring all the chemistry, which may give some of you a heart attack on this slide, is the ester group on the left-hand side of your screens. Because in most human beings, obviously, there's always that random human being that can't break down ester groups. Ester groups allows the remifentanil to be broken down so quickly, which is great for anesthesia because then it has a context-insensitive half-life. So even if I give remifentanil for God knows how long, 7 days in an ITU patient, I can easily turn off the remifentanil, and if the person's organs are all functioning very well, I can it's essentially like an off switch. I'll be like, bang, remifentanil's gone off. Within 2 minutes, he'll be awake. Obviously, within reason. So that's why it's such a good drug in that regard. Don't be giving remifentanil to outpatients, please. Okay, next slide. This is just propofol, the famous Milky Drug. This is just to highlight how it works. It's essentially hyperpolarizes the cells and therefore unlikely to depolarize. And obviously, the reason why it looks milky, it's basically full of a lot of fat, so it can easily go through most tissues. It's lipophilic. And as you remember from your plasma membranes, there's a lot of lipids in them, and they happily let them through within reason again. Okay, yes. Now this is a big one. So this is in relation to abdominal surgery and mostly laparoscopic and also a little bit in laparotomies. So if any of you have seen laparoscopic surgery or gotten involved in laparoscopic surgery, in order to put those arms into the abdomen, they need to put those trocars in, and then they essentially blow up the abdomen with carbon dioxide. And this is not just to make the patient look fat, it's to allow us to have more room to do the magic of surgery. Now, obviously, if someone is tense and if someone's abdomen is tense, when I mean tense, I don't mean ascites tense. Like if someone's contracting the abdomen hard, whether that be due to poor anesthesia or in pain, etc., and you were sadistic enough to put a trocar into them whilst they were awake and contracting the abdomen, you would need to put a lot more gas in them to combat that increased abdominal muscle contraction. So the thing that requires the anesthetist and the surgeons to work together is the anesthetist needs to give obviously a good deep muscle block so the abdominal muscles are relaxed. So then when the surgeon is putting the gas in, they can put a minimal amount. Now, how can this help the surgery, you may ask? So obviously, if you're increasing the intra-abdominal pressure, there are a lot of blood vessels in the abdomen that we know about. If we're literally squishing them with gas, you're going to number one, the first thing you're going to do is you're going to impede the venous return back into the liver and then back into the heart, and therefore reduce the cardiac output, and also reduce the body's ability to get rid of wastes. That's very simply. And the other way around is you're increasing the arterial systemic vascular resistance. So you're increasing the afterload. So the heart would need to work harder in order to perfuse the part of the abdomen the surgeon is working on. Lastly, it will also, because you're increasing the abdomen and the more gas you put in, you've seen it as well with the patients who have a huge belly, whether it be due to constipation, ileus, etc., you can't take as big breaths in. So we're going to have to use higher peak airway ventilation pressures, and that leads to a whole plethora of complications. It can lead to barotrauma, reduced ventilation in the bases of the lungs, especially when they're lying down, and therefore reduce good outcomes. Okay. Again, I'm not going to go on. Ben described it beautifully. Okay. The anesthetist is normally in charge of the fluids being given in surgery, and obviously, if the patient is crashing, we need to, deal with it. So it's very difficult. It's not something that you can protocolize. But the main thing is, if it's like your standard appendectomy and it's going well, there's no need to go ham with the fluids, okay? The whole point of giving fluids is to maintain their euvolemia. Obviously, in surgery, the person is mostly naked. Even with the bear hug and stuff, there is insensible losses occurring all the time. And even when there's an open abdomen, there's even more insensible losses. You've got an open book, essentially, with fluid leaving the abdomen. So obviously, it's like baking. You got to get the right ingredients in the right place, and that requires skill and experience. That's why you can't protocolize it. And again, avoid hypovolemia for obvious reasons. You don't want the person to essentially go into hemodynamic shock. And hypovolemia, again, the fluid in this system is doing nothing. You're going to ruin the kidneys. You're going to cause venous distension. And furthermore, you're going to ruin the wound healing because obviously edema, is fat, is tissue full of fluid. And obviously the wound healing process can't occur effectively. And that can further exacerbate the actual anastomosis the surgeon may make in colorectal surgery, and that can lead to horrific consequences. Now, postoperative optimization. This is the final hurrah of the talk. I'm not going to go into every single little detail in major detail, but the major things I'm going to talk about are gastric drainage, the famous NG tube. I know anyone who's done a surgical placement has been forced to put these into people, obviously with their consent. But I'm going to go through some myths about them. And, if anyone's working with any old school surgeons, you may want to put this in front of them because it may open their mind to new things. I'm going to be talking about analgesia postoperatively. From the prophylaxis, we all know about fluid. You're probably sick and tired of me talking about fluid, and a bit about hypoglycemia and why it happens and how we can manage it better after surgery. Early mobilization, I'm not going to talk about it, but it's logical. A patient laying in bed all the time isn't recovering. They're going to lose their muscle mass, and we're humans, we're made to move. So we should be encouraging it, and it stops pretty much stops all the complications we mentioned above. So I'm going to go through some myths. So a lot of people, a lot of medical professionals, I should say, think that, oh yes, leaving the NG tube, slapping it in, again, this is not a feeding NG tube, this is an NG tube for decompression. It reduces post-operative nausea and vomiting. Okay, and the other one is it reduces post-op gastric distension and therefore accelerates recovery. There has been a plethora of meta-analyses, which I'm going to link you all the data, by the way, just to prove we're not just talking without any evidence, have shown that obviously with a foreign object stuck up someone's nose, going down into the stomach, yes, okay, fine, it is in the stomach, but what has he had to go through? It's had to go through the nose, the upper respiratory tract, and then down into the stomach. Now, that tube is just sitting there. It's not a sterile tube, it's far from sterile, and it disturbs the flora of your upper respiratory tract. And it can actually, there's been shown that it can lead to more upper respiratory tract infections and therefore even lower respiratory tract infections, which is what we don't want after surgery. Yes, vomiting episodes do increase without an NG tube in, but if we can optimize it with the antiemetics, then hey, we don't need an NG tube. Furthermore, it actually accelerates return of normal bowel function. And obviously, an NG tube in there is not pleasant. I haven't had one in personally, but patients really don't like it. I can confirm that. And obviously, with that tube in, it doesn't make eating pleasant. What I mean is, if you have the tube in and you're eating food, you've got a tube blocking, not blocking, but disturbing the passage of food down into your gullet. It's not nice. So obviously, NG tubes are needed. If someone's in bowel obstruction in ileus, yes, there's evidence to show it helps in those situations. But in a normal elective procedure, which hopefully with no complications, NG tubes should really be used intraoperatively, especially in the extended procedure, especially where gas anesthesia is used and also the oxygen delivery, just to decompress the stomach because of the excessive gases that may go in there. Because it's impossible for us to get all the gas within the lungs pre-intubation, not post-intubation. Okay. Postop analgesia, again, Ben, it's exactly the same formula copied and pasted from preoperative optimization. You want regular analgesia. You don't want PRN because, number one, patients are frankly rubbish at knowing when they need pain relief. As humans, we're very reactive, not very proactive. So they'll be begging for paracetamol when they're in agony, but we should prevent that agony from occurring in the first place. Number one, it helps recovery. It makes them more comfortable and therefore reduces the stress response and allows them to recover properly. So give them regular paracetamol, give them COX-2 specific NSAIDs with an oral PPI cover, not IV PPI that has a plethora of complications. The other thing as well is obviously if they're in renal failure or if they've got a huge gastric ulcer, please don't give them an NSAID. Magnesium sulfate has shown some good effect at actually helping with analgesia and many other things. Ketamine, if your hospital has a policy on it, and obviously if the patient needs it, it can help in the short post-operative period. Gabapentinoids, so that's pregabalin and gabapentin, within reason can also help as well. Obviously, I'm not trying to say opioids are horrific, obviously, but try and minimize their use. Try and get them on a regular analgesic regime, which works, and obviously work closely with your pain teams. Obviously, if none of this works, you can use long-acting opioids, but remember, like with any medication, start low, go slow, and increase it to the patient's need. Okay, and this is just some more niche post-op analgesia. So anesthetists in many more specialized units can use epidural blockade using the thoracic region. They're really good in regards to pain relief because you shut down the nerves, and obviously it stops us having to use oral or IV medications on the wards. within a certain time post-operatively. However, they're very difficult to look afterwards. You need skilled nursing teams, and you also need a lot of anesthetists to make sure that the right meds are being given through the epidural catheter. A complication, very very typical physiology question they may ask you with epidural blockade is, if you remember from all those years back in physiology in med school, your sympathetic system runs in your thoracolumbar region of your spine. So obviously, if you're putting in essentially a long-acting version of lidocaine through the epidural catheter and shutting all those neurons down, you're also shutting down the sympathetic nervous system. So obviously, it can lead to with unskilled use, it can lead to hypotension, maybe with some bradycardia, because obviously you're shutting down all those neurons. So you need to really know what you're doing when doing it. But obviously, it's good to know, especially if you're the junior being called to see patients on the ward who have this method of analgesia. Now, another one, which you may have seen, especially with laparotomy patients, abdominal wall blocks. You may see patients wearing this weird bag on the abdomen above their midline wound. So essentially, it's again bupivacaine, a very long-acting sodium blocker, similar to lidocaine, obviously a lot longer acting, which is just underneath the rectus abdominal muscles and giving constant analgesia, basically numbing the area of the surgical wound. Again, it's great. It leads to less opioid use, but again, it requires a skilled individual, i.e. an anesthetist, to refill the bupivacaine and also to insert it most of the time. And also furthermore, it only lasts about 8 to 10 hours. So it's usually used, in my trust at least, in the immediate post-operative phase. But obviously, we can't rely on it. We can't be like, oh yeah, the patient's got no pain 8 to 10 hours. Don't need to prescribe any other analgesia. Trust me, when that bupivacaine or the abdominal wall block finishes, that patient will tell you, or you will definitely hear them down the corridor, that they're in a lot of pain. So you want to again proactive, not reactive. Okay, I'm not going to go through this much. We all are probably sick and tired of hearing about thromboprophylaxis. Again, is needed after surgery. The patient's going to be lying still. They're brewing clots. If we don't do it properly. If they've gone through trauma, you want to give them their regular prophylactic dose of low molecular weight heparin or unfractionated heparin if their renal function is that bad. Mechanical thromboprophylaxis, whether that be the special stockings, whether that it be the flotrons, the special stockings that squeeze the lower leg. Now, if someone's had big colorectal surgery, especially a big laparotomy as well, the guidelines say 28 days post-operatively prophylactic clexane should be given. Now, there's a bit of contention in regards to laparoscopic procedures about the evidence of, do we really need 28 days post-op prophylaxis for laparoscopic procedures, especially if they're minimally invasive. We sadly haven't got enough data about it yet. So a lot of centers that I know of are still, again, it's a common thread, especially in UK medicine, is, oh, we're just going to use what we know, and they are still giving 28 days post for prophylaxis. But who knows? Watch this space. This may change if a center is actually looking into it. Post-operative fluids, again, you're probably sick and tired of hearing us talk about fluids. I'm not going to go onto it too much. Maintain euvolemia, okay? If the patient can eat and drink, don't give them fluids as well. Look at their urine output and things like that, and obviously meet their needs. Now, what fluid? Again, you should be catering it to the patient's needs. If they're low on potassium, if they're not eating much, you may need to give them some glucose and potassium. Don't just bang saline or Hartmann's in them 5 liters a day, because that's going to lead to horrific outcomes. Now, one thing I see a lot of people who try to be clever on ward rounds is just go, oh yeah, the urine's dark, they need fluids. So looking at the color of urine post-operatively especially is not a very good indicator for someone's fluid balance. Number one, this is because the body's gone through a stress response. Big surgery leads to essentially a very mild version of distribution. So like sepsis, distributive shock, but similarly, our capillaries do get more leaky and leak fluid into the interstitial space. A lot of clever renal doctors have made lots of guidelines, which I'm going to link in the paper at the end, where they actually advise rather than us treating it and treating the numbers and try to get the urine output between 0.5 to 1 milliliters per kilogram per hour, they say we should do permissive oliguria, 0.2 to 0.5 milliliters per kilogram per hour. Now, obviously, this may lead to some scary slight rises in the creatinine and slight reduction in the GFR when you do your daily use and ease, which again, debatable. You should be doing daily use and ease on everyone. But this requires obviously a skilled look upon. So obviously you should be looking at the patient and checking their fluid balance. But permissive, I'm emphasizing this, permissive oliguria has shown to lead to, especially in the first 48 hours post-operatively, has shown to increase outcomes, better outcomes after surgery, without causing any, I'm going to emphasize this, permanent renal damage. So I'm not telling you to give the patient acute tubular necrosis. I'm just advising don't go too ham with the fluid. All right. Again, I'm not going to go into this side in crazy detail. There's a lot of emphasis in the paper I'm going to show, but essentially, this is a summary of the mechanism of how people can have post-operative hyperglycemia. The long and short of it is they go into an inflammatory and stress response, like when we're running away from a lion. Okay, we need increased sugar for our muscles, and that's what the body thinks is going on. And due to all of this, it blocks insulin from doing its job, and therefore leads to increased BMs, because we're going to be using increased fatty acids to fuel our body, and furthermore, we haven't got as much insulin to suck that glucose, excuse the term, into the muscles because of the actions on your screen. So what are we going to do about it? So obviously, pseudodiabetes does occur after surgery for the reasons on the previous side. Now, if someone's BMs are like 30 plus post-operatively, we got to deal with it, okay? You can lead to osmotic shifts in fluid. People are going to be urinating like hoses. Muscles, white cells, and tissues in the brain aren't going to get the glucose they need to survive. We all need our brains, okay? So now, the ERAS pathway indicates that strict insulin therapy should be used post-operatively to avoid pseudodiabetes. Now, again, this needs to be done by skilled individuals with intense monitoring, because you don't want your post-op patient who's gone through an operation successfully and then they suddenly go off because they have a hypoglycemic episode. So in the immediate post-operative period, you should get diabetes teams involved, as well as using your knowledge of insulin to try and cater the need. And obviously, this should only be within the first 24 to 48 hours. This shouldn't be lifelong diabetes. It's pseudo-diabetes, so it's a temporary increased sugar state, one might say, due to the stress response. Now, this is mostly the end of the talk. I'm just going to quickly run by this. So obviously, we'll talk about the European enhanced recovery after surgery guidelines. I've just included some reference slides of the Association of Anesthesia of Great Britain and Ireland. That needs to be a B, not a P. I apologize. Guidelines, just to show the slight differences. So in the UK, actually, we mentioned that a HB target of 80 plus is actually okay in ERAS. In the UK, they want 130 plus. Again, this is due to different evidence that the UK uses, and obviously nice guidelines. The rationale, again, as Ben mentioned, blood transfusions can worsen outcomes. The rationale why we still really don't really know. And obviously, again, 130 is quite a far cry of a target we want. We can't optimize people for years before surgery. They need to have the surgery. But we need to optimize the best we can by finding the cause and fixing it. But again, if someone has a huge fat tumor in their transverse colon, which is bleeding every day, that is the cause. No amount of iron, B12, folate, or blood transfusions is going to fix that. So obviously be logical. And the last one is glycemic control. I'm not going to go through the NICE guidance, but NICE guidance says that strict glucose control post-operatively shows no benefit in multiple fields as per NICE's study review. If you're sad like me and look at it in more detail, NICE, as stated by some of our friends, obviously, we call it the National Institute of Clinical Excellence. A lot of my friends actually call it the National Institute of Cost Effectiveness. If you look at the studies they use, they have a line at the end which says, even though some of these studies show that strict postoperative glycemic control improves outcomes, no study emphasizes on the cost benefit. So take that evidence as you will. And that is the end of the talk. Any questions, please fire them away. And yeah, I hope you enjoyed it. And Ben, if you have anything to add, please make yourself known. But if any of you have any questions, or if I went through anything too quickly, please make yourself known. Otherwise, please provide us feedback.
No, I've got nothing to add. Thank you, everyone, for turning up and listening to us.
Yeah, thank you. Oh, and more importantly, thank you for coming to all of our talks that we've hosted. And yeah, it would be really good to hear your feedback. And if you want to hear more about peri/pre/anesthetic stuff that we can try to teach you about. I'm going to hide my face now. There we go, showing it too much. Oh, George, right? That's a very good question. So obviously, yeah. So if we lived in a robotic world, 7 to 11 or 7 to 10 would be the optimal target. But essentially, what you want to do post-operatively is you don't want the person to be in a hyperglycemic, hyperosmolar state, or even in a ketotic state. That's the right term. So yeah, you want to essentially stop them being in those danger zone areas. Yeah, so there's no fixed number, but you should keep a strict control. So I'll like 7 to 20 would be ideal post-operatively. But yeah, if you could somehow magically get them into 7 to 11, whether it be for variable rate insulin infusion or a very good bi-basal bolus regime or something, that would be great. There's no single correct answer. Sorry for such a vague answers as well. I really wish I could just say yes.
I think it's important to remember that, as Amar said, it is a temporary response to the stress. So just be reassured by the fact that it will settle. We do often overtreat glucose, and I've done an endocrine job, I've done surgery jobs, and we always overtreat it. And actually, a lot of the times causes more problems than not. So just sit and wait. I think as well, I think it's patient specific, I'd say. I think in certain patients, for example, in elderly patients, we tend to have a bigger scope of what we'll accept, especially post-surgery when people are much more prone to sugar fluctuations. We don't want to be over-treating elderly people with hypoglycemia. A sugar of 20 is fine in someone for a few days. I'd rather that than stick someone in a hypo when they've just had surgery by giving insulin naive someone insulin. So just be reassured by the fact that it's probably not going to cause many issues, and it is just a normal response to things.
I agree. I'm just linking you guys the actual article where most of the source information comes from, which includes references to where that information came from. It is free. You don't need to use Sci-Hub, which I think is sadly down at the moment, so you can download it directly. To also prove that we weren't making this up. Shall we just wait? What was it? 5 more minutes for any more questions, Ben, and then call it.
Yeah, sure. Yeah.
Nice. Right. Oh yes, and for all those that have the joy of having to do F1, F2 portfolios, please download your certificate and slap it on your ERAS. It's a free hour.
Cool. I'm gonna head Amarinder, get some
Cool.
food.
Nice one. All right, nice one. We smashed it, bro. We finished.
Yeah.
See you later, man.
See you, dude.
All right. Thank you to all those that attended. I'm also going to have a shower. Really appreciate it. If you do want us to present any more stuff on perioperative care or anesthesia or whatever, or intensive care, please, send some stuff to Mind the Bleep, and we may be able to sort out. Otherwise, I wish you all a good evening wherever you are. Good morning, good afternoon, and see you later. Bye bye.